Hi, I'm Dr. Felice Gersh, your integrative OBGYN, here to talk this time about estriol. Now, just a quick recap on the estrogens. Estrogen is not a hormone. It's a family of hormones. Think of fats. Fats are not all the same. You have saturated fat, you have different fatty acids, you have omega-3, you have omega-6, you have monounsaturated, that's like olive oil. So they're not all the same. They don't have the same effect on everything. The same thing with estrogens. So in the human female, I'm going to stick with females here, there are 3 estrogens that are made by the human female body. And they include the one that is the dominant estrogen made by the ovaries during the reproductive years, which is 17-beta estradiol. We call it estradiol. And it has the symbol E, a big capital E, and the number 2. Then there is E1, big E, and the number 1. That is estrone. Estrone and estradiol can be turned back and forth between one and the other by an enzyme. Now, we'll talk another time more about estrone, but not this time. Just know that estrone is in an equilibrium state with estradiol in a healthy reproductive age woman. Now, then there is E3, the one that we're going to focus on today, and that's estriol. So there's E1, E2, E3. There's also E4, which is actually getting a little press these days, estriol. Estriol is a fetal estrogen that is in all fetuses. It's made by the liver, and it is in every fetus for a short period of time. I mention it only in that they now have a birth control pill that contains that fetal estrogen, and also it exists in a postmenopausal hormone preparation. So the bottom line is that estriol may be more in the news, and we'll talk about it another time. Back to E3, estriol. Now, it really pains me that there are what some might actually call the estrogen wars, because many of us who are very pro-hormone therapy, because we think of hormones as just really essential parts of cellular functionality. And if you're deficient or insufficient in a hormone, the obvious thing is to replete it, to give it back. Just like if you're low in thyroid hormone, we don't wait till you have none, and we don't try to make it the tiniest amount that you can live with. We try to make it a physiologic, biologically compatible level of thyroid when we give thyroid to people. Well, that's my approach with hormones in menopausal women and perimenopausal women, to try to get the hormone levels to be in a consistent way with what a woman would have when she's healthiest, like in her early 20s, because that's what cells need for optimal functioning. It seems pretty obvious. If you give thyroid hormone, you want to give an optimal amount that is consistent with optimal cellular functioning. If you're going to give estrogen, you want to give an optimal amount for cellular functioning, and the optimal amount is going to be what a healthy young person makes naturally. And what does a healthy young reproductively aged fertile woman make in her ovaries? She makes E2 estradiol. Does she make estriol? No. However, some estradiol is converted in the body from estradiol into estriol. That's where estriol comes from, and all women who have estradiol will turn some of it into estriol. Now, let's talk about what estriol does in a reproductive aged woman. Well, it has receptor binding affinity. It can bind to certain estrogen receptors. It is a weak estrogen. By that I mean it is a weaker agonist. It's a hormone that binds less potently to the receptors compared to estradiol. Now, what receptors does estriol bind to? What we know is that it binds predominantly to the beta receptor, and it binds a little bit to the alpha receptor. Now, I'm going to talk about another receptor in a second. So there are 3 types of estrogen receptors, and there are variants even among these 3. For example, the alpha receptor is the estrogen receptor that is positive in breast cancers that are estrogen receptor positive, but it's not every type of alpha. There's apparently 2 types. This is what we know so far, and it's one type of the alpha that is positive in breast cancers that are estrogen receptor positive. Now, there is a very small amount of binding of estriol to the alpha receptor. So about 80 to 90% will bind to the beta receptor. So the beta receptor is one of the other kinds. So there's alpha, beta, and a membrane receptor called G protein coupled receptor, or I nickname it Jeepers. And so it's G-E-P-E-R-S, Jeepers. Now, all of these receptors are important, and not only are they important, they actually interact with one another. For example, if you have a lot of activity on the beta receptor, a lot of binding to the beta receptor, it actually downregulates or makes less functional the alpha receptor. There's a lot of interactions. Now, I mentioned a membrane receptor. So these estrogens, the alpha and the beta receptors, will exist in the nucleus of the cell, okay? But it turns out there's some activity on the cell membrane, the outside. So it's more complex than we originally thought. We thought originally that alpha receptor and beta receptor were nuclear receptors. In other words, the estrogen had to be carried in from the outside of the cell through the cell membrane into the nucleus of the cell. That's like the brain of the cell, where it would then create activity through predominantly estrogen, what are called estrogen response elements, but not always. There's other ways too. And then it would then ultimately create the production of some kind of a protein, like an enzyme, on the ribosomes. Okay, and that's outside of the nucleus. It's a complicated thing. And then the product can then be modified, what we call post-translational effect. So you don't have to have a lesson in cell biology, but just know it's complicated. And we thought originally all the activity of these receptors were in the cell nucleus. Now we know that's not true. They're also on the cell membrane. And it's complicated because, once again, like I said, these receptors can interact with one another, up and down regulate each other. So there's alpha and beta, and then there's the G protein coupled receptor, which seems to be purely on the cell membrane. Well, I mentioned that estriol binds 80-90% to the beta receptor, and that small amount to the alpha receptor. Well, guess what? It may, and we call that an agonist, when it binds and then it activates the receptor. Well, the estriol may also bind to the G protein coupled receptor, Jeepers, but it may act as an antagonist so that it downregulates it. So acts as kind of a blocker. All of this is supposed to happen. It's about how the complexity of the cell is regulated by these different forms of estrogen in different situations. Now, when women are pregnant, the dominant estrogen that's made in the placenta turns out to be estriol, E3. And it's the placenta also makes estradiol, E2, and some of the estradiol will be converted in the body to estrone. But it's really complicated. Pregnancy is a really complex state of being and very unique because a pregnant woman has to support a fetus. It's a very unique state because she has to have much higher blood volume. Her heart needs to pump harder. She needs to modify her immune system so it doesn't attack and kill the little embryo and then the fetus. And of course, you have to modify everything to allow implantation of the embryo into the uterus. It's like amazing. The immune system has to change. The endocannabinoid system has to change. So much has to change. The thyroid function is changing. And it's unique for so many reasons to allow a fetus to grow and a woman to have an ability to protect herself when she's pregnant from invasion of pathogens like bacteria and viral infections, but yet not have her immune system in a state that it's going to attack and kill the fetus. So it's just an amazing state. I did deliveries and took care of high-risk pregnant women for 25 years in my practice. So I had to learn a lot about pregnancy. But we're not talking about pregnancy when we're talking about reproductive aged women, or especially perimenopause and menopausal women. Why would we want to even consider trying to replicate the complexity of what's going on hormonally in a pregnant woman? I'm not even getting into the progesterone part right now, but I can tell you in pregnancy, the production of progesterone is ridiculously high, and you would never see such levels in a non-pregnant woman. So it's a very unique state. Now, in terms of this so-called estrogen wars, which I said pains me, is that there are many well-meaning doctors and practitioners who are prescribing a lot of estriol combined with a little bit. Now, why would I be against that? Because it's not consistent with anything that's ever found in a woman's body at any time in her life. Not in pregnancy, not when she's not pregnant, never. Typically, what's given is a ratio of 80% of what they give is estriol and 20% is estradiol. Well, that doesn't exist in nature, and certainly not in a non-pregnant woman. And we're not even talking about levels that would even be vaguely close to a pregnant woman, and the progesterone isn't there. We're not trying to recreate pregnancy. Pregnancy is a very risky time for a woman. Women who are pregnant, that's the ultimate stress test for reproductive age women. Many women fail that stress test and develop things like gestational diabetes and preeclampsia and gestational hypertension. The last thing we want to do is put women's bodies in a situation where we're stressing them when they're going into menopause or in menopause, which already is a stress state and a highly inflammatory state. So we're not trying to do this. When you go through pregnancy, you automatically get an altered gut microbiome, you get leaky gut, you get some degree of insulin resistance, all for the purpose of growing a baby, producing a lot of fat quickly in the mother, and growing a baby quickly. And it's very thin ice because a woman can easily cross the line or break through the ice and develop these pregnancy metabolic complications. Why would we even think of doing such a thing? And in pregnancy, the woman's immune system, in order not to kill the fetus, has to be somewhat down-regulated. And that's where there can be some benefit to estriol. But I'll talk about that in a second too. Because a pregnant woman is more prone to complications and even death from infections like COVID, the flu, chickenpox, and so on, because her immune system is down-regulated so that it doesn't attack and kill the fetus. The last thing that menopausal women need is an immune system that's in any way compromised, because we know that menopause is a compromise to a woman's immune system. After menopause, women will have a higher fatality rate from sepsis or other causes of infection. So we do not want to take women who are aging and then put them into any compromised system for their immune system. That doesn't make any sense at all. So forget about pregnancy. We're not trying to replicate pregnancy. Now, I mentioned the immune system is modulated in such a way during pregnancy that this could be opening the door to some benefit from estriol. And in fact, because estriol is kind of like an immune modulator, it reduces the immune response so that women don't kill their fetus. Well, what about certain autoimmune conditions like rheumatoid arthritis, or the most studied one is multiple sclerosis? Well, when women have these autoimmune conditions and they get pregnant, they will often go into a remission. They actually dramatically improve. And estriol is the reason for that. So it might be, and there is some research on this, that not treating menopause, but treating autoimmunity, that estriol may have a therapeutic role. Now, in that case, we're not treating estriol, E3, as hormone therapy like for menopause. We're treating it as a pharmaceutical to treat an autoimmune condition. And the same would be true for breast cancer. I mentioned that breast cancer that is receptor positive for estrogen, it's one form of the alpha receptor. I also mentioned that when you have high estriol, that it tends to downregulate the effect of the alpha receptor. It like makes it less functional. So there can theoretically, and this is actually in years and years ago, like a few decades ago, this is before the development of a drug called tamoxifen, that estriol was used to treat breast cancer by downregulating the receptor that estrogen, and we're not going to talk more about breast cancer because that's a very complicated subject that we've dealt with and we'll deal with again another time, but that particular form of the alpha receptor is somewhat downregulated by estriol. So there can be a potential role for estriol in women who've had a history of breast cancer. Also, that other estrogen from the fetus, estradiol, that I mentioned, which actually does not bind at all to the particular, at least as far as we know so far, the receptor that is the alpha part of the receptor that's involved in breast cancer. So these forms of estrogen, estriol and estradiol, may have a role in breast cancer treatment or breast cancer patients who want to go on hormones. So perhaps we need more data on all of the above. But what about looking at women who simply are regular women and they are going into menopause? They're perimenopause, they're menopause. Why not give this Biest, where you give predominantly estriol? I mentioned 80 to 20. 80% of the product is estriol and 20% estradiol. Some people now, because there's been a little pushback or because they realize it, are now doing 50-50, 50% estriol, 50% estradiol. But, and not in all cases, but at least most classically, the amount of estradiol that's prescribed is really little. Now, what if someone prescribed a really reasonable amount of estradiol and just a smidgen of estriol? I mean, it probably is okay, but what's the point? What are you trying to accomplish except increasing perhaps the cost? Everything should have a purpose. So I'm not saying that estriol is dangerous or that it doesn't have benefits because it binds to estrogen receptors. That's all good. What else binds to the beta receptor predominantly? Well, guess what? Most of the phytoestrogens. Isn't that nice? Like things like eating soy and eating apples and having flaxseed. These all mostly bind to the beta receptor. And they can help with a lot of things. So I'm not against the beta receptor. I'm pro-estrogen in every receptor. But I feel that we are not smart enough to try to micromanage estrogen receptors. What works the best is giving estradiol and then letting the body self-regulate, allowing the body to convert estradiol to estrone, E1 when it's indicated, to allow estradiol to convert to estriol, E3, when it's indicated. We don't deal with that. We don't think about, okay, now convert here, convert there. Different organs in the body have a different propensity of different receptors. And what am I afraid of if you give predominantly estriol in the classic way that most of the prescribers are giving it, where they're giving predominantly estriol and just a tiny smidge of estradiol? Well, I already mentioned that, one possibility is that estriol will downregulate the membrane receptor called GPRS, G protein coupled receptor. Well, that matters. All these things are supposed to be in this beautiful balance that the body controls. We are not smart enough to control these things by pushing one thing or another with the receptors. So what about Jeepers? What does Jeepers do? Why would we not want to downregulate it? Because Jeepers is really important. It's present in many different organs, and it regulates a lot of metabolic functions in the body. So nature gave women who are not pregnant the dominant estrogen, estradiol, because you need estradiol, which binds to all the receptors. So estradiol binds in a perfectly balanced way to alpha, beta, and the G protein coupled receptor. Estriol comes from estradiol when the body wants to make it, and it does make it. It's present in all menopausal women who are taking estradiol. It's not like we're anti-estriol. Let the body convert estradiol to estriol when and where it wants it. Different organs have a different propensity of alpha, beta, and G protein coupled receptors. So the body will convert estradiol to estriol, to estrone, which binds predominantly to the alpha receptor, where and when it wants it. And estradiol itself is critically important, not just for its direct binding to receptors, but also for its metabolites. So one of the metabolites that estradiol is turned into by the liver is called 2-methoxyestradiol. It has receptors on the heart, in the heart, and it actually promotes the activation and health of mitochondria for creating and maintaining energy. It's involved in many metabolic functions. This is an estradiol metabolite, not an estriol metabolite, an estradiol metabolite. There are also receptors that will not properly bind their ligand, what binds to the receptor, without estradiol present. They're called estrogen-related receptors. And what needs to be present is estradiol, not estriol. So many really critically important organs, like how about the heart, the brain, they use the estrogen-related receptors. They use the estrogen metabolites, like 2-methoxyestradiol, to actually create energy, to maintain metabolic health. And you don't get that from estriol. So estriol matters. It comes from estradiol. It's made in large quantities by the placenta in pregnancy. Pregnancy is a very unique time and a very risky time for women. There's a reason why we want all women to be optimally healthy before they conceive, so they don't get into trouble with complications. We're not trying to replicate pregnancy in a menopausal woman. What kind of sense does that make? We have receptors that need to be activated in all the different organs at the right time, in the right way. They interact with one another. You and I are not smart enough to micromanage these things, so we shouldn't even try. If we give estradiol along with all the lifestyle, the nutrients, the macronutrients, the micronutrients, fitness, sleep, stress reduction, avoidance of chemical toxicants, if we do everything lifestyle-wise, and we then give the types of hormones that should be present in the body to create the proper instructions to the cells so that the cells will do what they should do to optimize their health and their function and their productivity, then we have the best chance, medical probability-wise, to have healthy lives and healthy aging. Let's not think we're smarter than nature. We cannot outsmart nature. You know what the biggest failed experiment of trying to outsmart nature? How about food that never spoils, ultra-processed food? How's that worked for us? No, we should not create hormonal regimens that never exist in nature, that we don't really know what we're doing. If we're going to use estriol as a drug to treat a certain condition, that's fine. That's not the same as giving hormone replacement therapy. We want to optimize a woman's health at every age to be optimized as if she were 21. Now, can we do that? Of course we can't. We simply try to do the best we can, and the best we can is to give the hormones that the ovaries make when a woman is at her healthiest. not some other concocted, not normal, not ever seen in nature combination of hormones. None of these hormones are evil. I love estriol. I love estrone, but everything in the right place, in the right amount, in the right time. The best way to have that achieved is by giving the hormones of the ovary, estradiol and progesterone.